genes on the growth and development of an organism of individual, including regeneration, reproduction, and metamorphosis. So the principles and processes include gene activation and repression, differential gene expression, role of several transcription factors which can modify the development or the cellular processes, and differential RNA selection, certain gene dosage effects, and dosage compensation. So the genes control the developmental processes including cell migration and the cell differentiation. So different organs and tissues have to be formed. So proper migration and differentiation is essential for the formation of a complete individual, in addition to apoptosis of unrelated or that what is not needed. So again, reproductive genetics, this refers to transmission of genetic traits to the fetus, the effects of epigenetic alteration of the fetus or embryo. So anyone, what is a embryo? And what embryo we say up to second month, up to the end of second month. In case of humans, up to the end of, there is a 9-month period, and up to the end of second month it is called a embryo. Then after the second month, when the proper structures organs form, it becomes the fetus. So it may also relate to the effect of a particular genetic disorder on conception, pregnancy, or fertility. So either the fetus may be having a genetic disorder because of some abnormalities occurring during the embryogenesis or fetal growth, or maternal genetic disorder can also affect in some way, like ability to be pregnant or ability to be fertile. So it includes effects of natural and assisted reproductive techniques. Sometimes the assisted reproductive techniques which are used, they may also cause abnormalities. So like imprinting defects and methylation abnormalities. So this reproductive genetics usually focuses with study of the genetic risks or conditions that can be passed from the parent to the offspring. So this is a book on reproductive genetics which is available, and identification of these genetic causes of infertility and recurrent pregnancy losses can be made by certain protocols. Then the effects and use of emerging technologies can also be studied. So these all are included under human reproductive genetics. So in the embryonic period, that is the early developmental period, and the fetal period, that is the later developmental period, important cellular processes occur. These include division and proliferation of the cells, cellular differentiation for varied functions, migration of the cells to form organs, and then embryo forms from the inner cell mass of that blastocyst. Then implantation occurs 7 to 12 days after fertilization. The formation of ectoderm, mesoderm, and endoderm occurs. The critical period is 3 to 8 weeks of gestation. And the craniocaudal axis is established, and then organogenesis occurs in the human embryo. So these are the different phases in which different organ systems or different tissues develop. So you can see in the initial period there is risk of neural tube defects. If later problem occurs, then there is a risk of mental retardation. Even cardiac defects, they occur in this early period, that is you see 3 to 6 weeks. So tricuspid atresia, truncus arteriosus, ASD and VSD, they occur in this period. Then amelia, mesomelia, limb abnormalities also occur in this 4th, 5th weeks. Then you can have cleft lip if there is abnormality in this period, any insult during this period, 5th to 6th weeks, cleft lip occurs. Then you can have eye abnormalities like microphthalmia, cataract, glaucoma. This occurs during 4 to 8 weeks. So different sensitivity periods are there for different organ systems, and accordingly the abnormalities may be found depending on the insult, at what period this insult occurs. So this maximal sensitivity to abnormal development is 3 to 8 weeks. Then after that, growth and maturation of organ systems occur, and so after that the main multiplication will be affected, so size will be affected after that. So there are several important genes or groups of genes which are important for the development. So these include the different FGFR family genes, the homeobox or Hox genes, as TGF beta pathway genes, the Notch signaling genes, the RAS family genes which are important for CNS and cardiac development, and Wnt signaling genes which is mainly involved in the skeletal development. So any abnormalities in the genes or in the processes can lead to certain abnormal effects like non-disjunction, imprinting defects, uniparental disomy, polyploidy, malformations, deformations, or stillbirths. So abortion, stillbirth, all these can occur if there is an abnormality in any of these genes or pathways or the processes because of any reason. So the problems in morphogenesis are usually divided in genetic terminology as poor tissue formation, which is called malformation, unusual forces on the normal tissue leading to deformation, breakdown of the normally formed tissue, that is called disruption, and abnormal cellular organization, that is called dysplasia. So we see multiple malformation syndromes or isolated malformations. We see also isolated deformations like Potter sequence or deformation syndromes. Then we have disruption syndromes also, and we can also have dysplasia. So different types of dysplasias can occur, like the different skeletal dysplasias. So one of the common defects or birth defects is cardiac defect in the humans. So incidence of birth defects involving brain, heart, kidneys and limbs is 10 per 1000, 8 per 1000, 4 per 1000 and 2 per 1000 respectively. That means the brain defects occur 10 per 1000 and heart defects occur 8 per 1000. But heart defects and limb defects can be easily picked up on the ultrasonography. So it is difficult to pick up the brain abnormalities. So nowadays fetal MRI is improving, and sometimes we rely on this fetal MRI. And in Indian population, estimated prevalence is 5.7 to 11.4 per 1000 births. These birth defects occur. And the common form of cardiac defect is VSD. This can be muscular or perimembranous. And the common syndromes with cardiac defect include DiGeorge syndrome, Noonan syndrome, Turner syndrome. So another common birth defect is neural tube defect. So there is in the embryo, there is the anterior neuropore and a posterior neuropore when this development occurs, and then the further development occurs to form the spine, and if there is a problem in this development, there can be encephalocele, meningomyelocele, meningocele, these problems can occur. So this is in the photo you have 25 days embryo that is shown with anterior and posterior neuropore. And these abnormalities include lumbar meningomyelocele and encephaly, in which the cranial vault formation is affected, encephalocele in which you have a cystic lesion on the front of the head or the back of the neck. Then you can have inencaphaly, then other forms like sacral agenesis, diastematomyelia, myelocystocele, and these can be syndromic or non-syndromic. NTDs are found to be common in Gujaratis, and in certain parts of China the NTD rates are as high as 1 in 200. So this is a photo of a encephalocele, that is a ruptured sac. So you can have a cyst on the back of the head, and anterior encephaloceles are common in frontonasal dysplasia, in which ALX3 gene is involved. Then you can have occult spinal defect, tuft of hair on the back. This gives a clue that underlying spine is abnormal, and there can be scoliosis. So different NTD syndromes include Meckel-Gruber syndrome, Walker-Warburg syndrome, frontonasal dysplasia, Waardenburg syndrome, in which you have heterochromia iridum or heterochromia iridis in the eyes, and other NTDs may be associated with new genes like WANG L1, WANG L2, hydin So hydin is a gene related to ciliary dyskinesia. So there was a surveillance for congenital anomalies, the Eurocat survey, which was over a period of 10 years, and they found that the prevalence of Meckel syndrome is 2.6 per 1 lakh in the European population, and the risk is higher in Belgium and Finland. And MTPs, around 75% MTPs were done after prenatal diagnosis. There were 6.8% fetal deaths, 17% were born live. And then in the Meckel cases, there were cystic kidneys, encephalocele, and polydactyly. Most frequent was cystic kidneys, 97%, and least frequent was encephalocele, 83%. So this is the triad of Meckel, cystic kidneys, encephalocele or meningomyelocele, along with polydactyly. Other CNS abnormalities can occur, like Dandy-Walker malformation, and fibrotic cystic changes in liver can occur in 60 to 65%, and there can be also orofacial clefts. So another condition is Hirschsprung's disease. This is a gastrointestinal malformation in which a ganglionosis occurs in the colon. So ganglion formation is abnormal, that is the myenteric plexus and mesenteric plexus are there in the GI tract. So in this, if aganglionosis occurs, then it can lead to constipation. So there will be problem in passing stools, constipation will be there. So it can be short segment or long segment type, and it is found isolated or in association with Down syndrome, Waardenburg syndrome, and sometimes Rett proto-oncogene is related. So there are many other candidate genes which can lead to Hirschsprung disease. So the congenital anomalies can be monogenic in 7.5%, chromosomal in 6%, and maternal illness or maternal infection account for over 5% of these cases. Environmental agents can also affect, and teratogens can also affect the development of the baby, like anti-epileptic drugs, warfarin, thalidomide. In some cases, the cause is still unknown, or maybe some genetic cause still not identified. So, like in many cases of cleft lip palate, and in cases of Vectral. So Vectral is a association. When you get a proper causative gene, we can call it a syndrome. Then nutritional factors are also there in case of neural tube defect, especially isolated neural tube defect. They can be because of especially folic acid deficiency. So teratogenic drugs include thalidomide, anti-epileptic drugs like carbamazepine and sodium valproate, and this is a child with fetal valproate syndrome. So mother was on valproate for seizures, and the child had some subtle dysmorphic features like prominent forehead, prominent philtrum, triangular faces, and in the hands you can see there was only one forearm bone and only one digit, single digit. So these abnormalities, in addition to NTDs, can occur with if mother is taking sodium valproate. So the newer anti-epileptic drugs like oxcarbamazepine, they do not cause significant fetal malformations. So for prevention, what do you do? So prevention is either a primary prevention or a secondary prevention. Primary prevention is from the beginning only if you prevent the first occurrence of the abnormality in the family. Secondary prevention is when one abnormality or abnormal baby is already there, and in the subsequent pregnancy you are preventing the reoccurrence, that is reoccurrence. So for neural tube defect especially, it is known that periconceptional folic acid starting from at least 2 months before conception in a woman planning pregnancy can help in reducing the chances of NTDs around 70 to 80%. So avoidance of teratogens in pregnancy like anti-epileptic drugs and thalidomide would also reduce the risk of malformations. Alternative drugs can be given, and prevention of maternal radiation exposure in pregnancy and hyperthermia prevention is important. So usually when we know that mother is pregnant, we avoid doing X-rays in the mother, because X-rays can lead to, or CT scan can lead to radiation exposure and there can be effect in the fetus. So low doses of folic acid are given for primary prevention of NTD and higher doses for secondary prevention. But in India we have 5 milligram tablets, and usually we give 1 tablet OD periconceptionally at least 3 months before, and even continue after pregnancy is detected. So preconceptional counseling if is there, then it will be better to start folate and give periconceptional folate for prevention of malformations. Sometimes this folic acid can also protect against cardiac and limb malformations, and combinations of B6 and B12 with folic acid are also available, and these can also be given. So now coming to reproductive genetics. So recurrent spontaneous abortions can occur in certain individuals, and this may be either due to a male factor or a female factor, or both can be there. So we say RSA if 3 or more spontaneous abortions or pregnancy losses occur, and if these are early first trimester losses, then chances of getting abnormal karyotype in one of the partners, either husband or wife, is higher. And balanced chromosomal translocations have been found involving usually 2 chromosomes, but there can be multiple chromosomes involved. So they are called complex chromosomal rearrangements if 3 or more chromosomes are involved. And these translocations can be reciprocal translocations or Robertsonian translocations. So reciprocal translocation we say when 2 autosomes are involved. Autosomes and 2 autosomes in which you have 2 arms, P arm and Q arm. So that will be a reciprocal translocation. And Robertsonian translocation occurs between 2 acrocentric chromosomes. So when acrocentric chromosomes are involved, one acrocentric chromosome joins to the other acrocentric chromosome, like 13, 14, 15, 21 and 22. So they are Robertsonian translocation. So in case of Robertsonian translocation, there is increased risk of aneuploidy in the offspring. So this is an example of a Robertsonian translocation. 28-year-old female presented for genetic counseling with history of 4 first trimester abortions. So karyotype was advised for husband and wife, and the wife's karyotype we found a abnormality. So you can see this chromosome 13 and 14, they are joined. So it is a 13, 14 Robertsonian translocation, written as Rob 13, 14. So in this case, since one chromosome is joined to the another acrocentric chromosome, so chromosome number, you can see one chromosome number is reduced. So the total number of chromosomes in that carrier individual will be 45 instead of normal of 46. So then coming to reciprocal translocation. This was another family with the previous abnormal child abortion, and in this you can see this was father was a carrier of a translocation T27 translocation was there. Here this is the breakpoint on chromosome 2, you can see breakpoint on chromosome 7. So 27 translocation was there. So this is a reciprocal translocation. So sometimes you can find normal variants on karyotyping, and one should remember that they are inconsequential, they are unlikely, less likely or unlikely to cause a phenotype. So inversion 9p and extra satellite over chromosome 21, then heteromorphism on chromosome 9, heteromorphism on chromosome 16. So like 16 heteromorphism is written as 16qH plus, 9 heteromorphism you can see written as 9qH plus. So then coming to infertility. Infertility refers to biological inability of an individual to contribute to conception. It affects 10 to 15% of the couples planning children. It can be primary or secondary infertility. So causes can be identified in over 80% of the cases with proper evaluation. And of all the causes, chances of genetic abnormality in the infertile male or female is 15% and 10% respectively. So in the male, 15% males can be identified to have genetic infertility, and 10% of the females with infertility can be identified as genetic infertility. So proper evaluation is required to find the cause of the infertility. So chromosomal abnormalities in infantile females can be seen in 5%, and Turner syndrome and fragile X-related premature ovarian failure are two of the important causes. In men, structural or numerical defects affecting the sperms leading to abnormal spermatogenesis occurs, and genetic causes in males include Y chromosome microdeletion, CFTR related gene mutations, and androgen receptor gene mutations. So this congenital bilateral absence of VAS difference can occur in the males due to CFTR gene mutations. So one should not forget to rule out the commoner abnormalities or causes like hypothyroidism, some infections like tuberculosis, especially in the females, leading to tubal blockage, and several autoimmune causes like SLE and other connective tissue disorders. So coming to antenatal diagnosis of the malformations. So antenatal diagnosis can be done by serum screening and a level 2 ultrasonography. Sometimes we do a fetal echocardiography or a fetal MRI. So maternal serum screening usually is done for Down syndrome, but it can also detect neural tube defect, which is a common malformation. Level 2 ultrasonography should be done ideally in the second trimester in all pregnancies, so that we can detect some of the gross malformations like spinal defects, cardiac defects, and limb anomalies. So now we have 3D and 4D ultrasound, which helps in better detection antenatally of the malformations. And if malformations are detected, further evaluation or confirmatory testing can be planned, like aneuploidy testing or chromosomal low resolution chromosomal microarray can be done if multiple malformations are there. And then if cardiac defect is suspected, or there is a previous history of child with cardiac defect, then fetal echocardiography can be done around 19 to 20 weeks to detect the major cardiac abnormalities. But one should remember that all the defects, abnormalities or malformations cannot be identified on an antenatal ultrasound, and some of these may be identified after 20 weeks of gestation, which is the usual cutoff for termination of pregnancy. Fetal MRI is also increasingly used modality in some centers for detection of the skeletal defects like skeletal dysplasias and CNS malformations. So you need appropriate expertise for detection of these abnormalities. So genetic counseling is important in case of any abnormalities identified. So in case of balanced translocation, risk of abnormal child will also be there, in addition to increased risk of abortions. So more the number of abortions, then higher the subsequent risk of abortions in the couple. And there is a condition called Kallmann syndrome, in which there is loss of smell along with infertility. It is an X-linked condition. And in case of men with Y microdeletions, increased risk of testicular cancer is also there, and in counseling this should also be mentioned. And some of the options for these patients with either balanced translocations or infertility is IVF and ICSI. IVF is in vitro fertilization, and ICSI is intracytoplasmic sperm injection. So with testicular sperm retrieval, so these are the reproductive options. So if we are using the sperm retrieval options, there are chances that the abnormality in the father will be transmitted to the son. So this should be remembered. So preimplantation genetic diagnosis, it deals with testing of for genetic abnormality in the embryo as an option when one or both parents carry a genetic defect. So this can be done for chromosomal abnormalities and also can be done for single gene disorders. So this is done prior to implantation of the embryo, and this can be done for couples at risk for severe single gene disorders, chromosomal abnormalities or microdeletion syndromes, and also mitochondrial disorders. So this is usually used in conjunction with IVF in selected couples who don't want prenatal diagnosis, or prenatal diagnosis is not an option for them. So many high risk couples like those with advanced age, this can be a likely option.